Ladies and gentlemen, we'll move on to the third presentation for the next 12 minutes. May I have the pleasure of inviting Dr. Vidyut Jain, Senior Consultant Cardiologist from Indore. Dr. Jain joins us to speak on Leadless Pacemaker, Potentials and Pitfalls.
Respected Chairperson and august audience. Today the topic is a bit odd in this particular conference. This is conference which is basically for preventive heart diseases. When Dr. Chopra asked me, okay, we have to discuss some different aspect and maybe some innovation you can talk. So then I chose the topic which is really very new for us, and we may learn here also as well. Leadless pacing. Many of you know the first time the pacemaker, when it was invented, it was something like this in 1957. And this was the person who received the first pacemaker, Larson. And this was the type of the pacemaker which was available in 1958. From there, where we have come? We have come to a smallest size of the pacemaker which can be implanted right into the right ventricle without opening the chest or without doing anything. But the technology has certain limitation. We knew that many of our patients who has a pacemaker, they come with the pacemaker lead breakage, and this is the main important thing. And more the leads, more the complication which we face in our day-to-day patient. So we have several limitations of the cardiac pacing, what we are doing today. We have patient going for sudden cardiac death related to the hematoma or sometimes lead dislodgement. Sometimes there may be crushed fractures in the leads, and sometimes the device pocket can have complication. Infection and lead interaction with vasculature of the heart, maybe tricuspid valve impairment. All these things can be answered by some other method. Anyway, we know if we do not do the proper management of this complication, many of them need repeat procedure and many of them can lead to the death. So there was some innovative person somewhere in 1970. He thought, why not there should be a pacemaker which can be implanted inside the heart. So there's no question of tackling the lead, no question of tackling the lead hematoma, no question of almost infection. So from 1970 to 2013, there was no activity. And this was his thought of putting a leadless pacemaker. But for almost several years, nothing happened. Then few things came. Can we put a pacemaker inside and do it charge from the ultrasound transmitter? Can we have a pacemaker inside and do we recharge with the magnetic field? Or can we have wireless electrical stimulation by radio frequency? All these three things were tested in the time. Ultrasound, you can put in an intracardiac one electrode and then you can recharge it from outside. But there are certain limitations, and it has been shown. If you do in this manner, you can always initiate the pulse and you can have patient effective cardiac output. But the limitation again did not allow us to go further because it had a lot of problem. Energy transfer was less, safety factors were less, and it required a very implantation at a very caudal side in the LV, and it was difficult to excite multiple intracavitary site, and safety issues were many. Hence, this also requires a very good acoustic window to recharge the pacemaker inside. And sometimes COPD, obesity, and sensing problems are main hindrance in continuing this technology. Then came very difficult proposition. You have and you can leave it also, and sometime if you need to relocate, it is also possible. And then the most important thing is how to retrieve it when the life is over. There is a definite method for that, which we can discuss afterward, but it is not very simple. The method has to be practiced first and then only to be applied. Okay. So these are the various ways to retrieve. The importance is it's not, it can be reprogrammable, and if compared with the pacemaker which are put conventionally, it has got various advantages, particularly that you don't have to have any pocket, you don't have to have any lead, and it can also last for 9-10 years. And one study was done in which 34 patients were taken, although one patient had groin hematoma, another had a perforation, which is very important thing, because everything cannot be very simple, although it looks very attractive. So now, intracardiac pacemaker, there are challenges. The fixation technology is difficult. Delivery system is very important. The power system has to be very clearly lasting for 10 years or so. And at the same time, it should have a stable pacing threshold These are all the things. So what are the potential risks of the leadless pacemaker? Sometimes you require very large bore catheter, 20 to 26, access challenges, hemostasis, vascular complication, and low stable chronic threshold, thromboembolic risk, and extraction may be difficult. Now, most important thing, I am talking of the pacemaker where you don't require any equipment. In approach to create pacemaker in a cell that previously had little or no pacemaker function. This approach modifies the electrical signal generated by cardiac myocyte and specialized conducting cell to transform them into the dominant pacemaker. And it's done by the gene therapy. Knock out the function of gene that would otherwise decrease the pacemaker rate. This is all possible, but it has to be done through virus which transmit all this genetic-based therapy, which has got certain problems and which may be carcinogenic or potential for neoplasia. This is the creation of a pacemaker in a cell that previously had little or no pacemaker function. Here you don't require any equipment. Here you don't need anything. You just need to modify the pacemaker function of the biological cell which is already there, and it's done through SCN channel. And this is one of the example in the animal where the pacemaker was generated within 72 hours of the gene transfer KIR2K. So these are all the things which are likely to see the future. And maybe we may be there or we may not be there. So leadless pacemaker, present status, is an attractive innovation. It's possible to avoid all lead and pocket related problems. So far only a small number of cases have been done, 40 or so. Large number of cases yet to be performed. Performance training needs to be very perfect, not feasible in children. So well, dear friends, this was basically not the topic which should have been in this conference, but Dr. Chopra wanted some other flavor should be added in all this type of the conference so we can learn from the experience of our dear colleagues who have come from all corners. Thank you very much.
Thank you very much, Dr.